Good evening and welcome to the final webinar in our May Brain Tumor Awareness Month webinar series. Our special guest speaker tonight is Dr. Brad Zacharia. Dr. Zacharia is an associate professor of neurosurgery and otolaryngology at Penn State College of Medicine. He's the vice chair for clinical operations and division chief of neuro-oncology and school-based surgery in the Department of Neurosurgery. In addition, Dr. Zacharia is the co-director of neuro-oncology at the Penn State Cancer Institute. Tonight, he'll share with us a presentation on the IMVAX Phase 2b trial for glioblastoma. Dr. Zacharia?
Great. Yeah, thank you, Vanessa. Appreciate it. So yeah, really glad to be here. And yeah, it's really a pleasure to be able to speak about this trial. I am one of the sites that's participated in the Phase 2b trial, which we'll be talking about in a little bit, and a lot of background work that went into this. So looking forward to speaking of some of the background of this trial and kind of where it currently stands. So as regards to the company, it's a clinical stage biotech company headquartered in Philadelphia. Their primary platform is the GoldSpire platform, and the idea is to deliver personalized whole tumor immunotherapies really across a spectrum of solid tumors. Its most advanced program is IGV-001, and that's currently being evaluated in a Phase 2b trial in newly diagnosed glioblastoma. But their portfolio also includes a number of programs designed to stimulate a patient's immune system against the entire antigenic signature of a tumor. And so you can see some more information here. So just going to start talking about some of the initial results from the Phase 1b study that obviously informed where we are currently with the later phase trials. So the results were published in CCR, Clinical Cancer Research, in April of 2021. This is a group led by David Andrews. He's a neurosurgeon in Philadelphia, whose kind of basic science research informed this platform and really led to this kind of landmark trial. So this was in adults with newly diagnosed glioblastoma. It was very broad inclusion criteria with no upper limit of age, no extent of resection requirements. And the primary endpoints were largely safety, being a Phase 1 trial. And so the treatment was with IGV-001, which is an autologous glioblastoma tumor cell, plus this antisense oligonucleotide against insulin-like growth factor 1 receptor, the IGF-1R receptor. And that's loaded in biodiffusion chambers. They're radiated to prevent cell proliferation, and then they're implanted into the abdomen. And it's designed to induce anti-tumor immunity. And so this was an open label Phase 1b trial. They randomized 33 patients into a 1 in 4 cohorts plus standard of care to occur 4 to 6 weeks following implantation of the chambers. And this was essentially a dose escalation trial, utilizing both escalation of the number of chambers, thus really the number of cells, as well as the exposure or the time. And so the 4 groups were 10 chambers for 24 hours, 10 for 48, 20 for 24, and 20 for 48. And after the 23rd patient, the protocol was amended for everybody to get the highest exposure, which is 20 chambers for 48 hours, because that was the most striking clinical and radiographic improvement without really any increased toxicities noted in that group. So just some, a standard table 1 here with basic demographics. You see slight male predominance, typical age range here from 30s up to the late 70s with an average around 63. There were patients with multifocal and bihemispheric disease. Obviously, those patients are typically excluded from most later phase trials. Only a very small portion had received a gross total resection, with almost 50% just getting biopsy only, and a wide range of Karnofsky scores, including patients with relatively poor functional status. It was overall well tolerated. None of the patients had any autoimmunity or morbidities reflecting a cytokine storm, which can obviously be seen with immunotherapies. There were 5 adverse events. All were less than or equal to grade 3 events related to the abdominal incision, so hematomas and wound infections and such. There were 4 adverse events related to IGV-001, included fever, incontinence, and some laboratory increases in ALT and AST. And so again, this just kind of shows that really, again, across the different cohorts, really no dramatic change in the incidence of some of these things. And most of these were felt to be unrelated. These are the treatment related adverse events. So while it was not powered to show a survival difference or to show that, what you could see here is that in the Stoop eligible patients who had the highest exposure, so those would be patients who with a slightly more stringent inclusion criteria that would have been in the original Stoop trial, utilized temozolomide and radiation. That those patients had a median progression-free survival of 17 months, which is significantly longer than the standard of care. And they had a median overall survival of 38 months, also significantly longer than the standard of care group. Again, this is in a much more selected patient, but again, I think it brings out the signal within the noise. If you look at the intention to treat cohort, there were significant increases in both median progression-free survival and overall survival, even in those cohorts, even with the very, very heavily unfavorable cohorts that were in this trial. Serious adverse events, grade 5 adverse events and deaths. So there were 24 patients with at least one SAE, none of which were considered related to treatment. We all know that these are patients who undergone chemotherapy and radiation with very devastating disease. So 6 patients experienced an AE grade 5, 2 were failure to thrive, 1 cardiac arrest, 1 MI, an episode of severe colitis, and then an episode of sepsis. In this cohort of 33 patients, 26 patients died, with 2/3 of them being attributed to glioblastoma progression. 35% of them were not attributed to glioblastoma progression. And most of these occurred within this short period of time or year after IGV 001, none of which were felt to be related to the treatment. So just as an example of some of these cases where, if I think you particularly look at C and D, where there's some residual disease, and then on the preoperative to the postoperative imaging on these T1 weighted axial contrast enhanced MRIs. And then you look at these kind of delayed scans, all of which are around the 3-year mark. You see sustained radiographic response. And again, this is median survival or median time to progression in patients who underwent a gross total resection in historical cohorts, about 9 months. And you see in this that median not even reached in the phase 1b trial. So really, definitely some signal that this is really having an impact. This is in patients with subtotal resections. So patients who fare substantially worse with an average survival to progression of 6 months. And in this, the median survival was nearly 3 years. So really dramatic change, sustained radiographic response. I mean, you could look at that row B here, where you see really just a small biopsy or sampling of this and dramatic disease response at 4 years. So clearly seems to be having an impact. Mechanistically, immune activation was found in the phase 1b study that supports an immune-mediated mechanism for this action as anticipated and based on the preclinical work. So peak elevations of pro-inflammatory interferon, IL-12, IL-2 that really happened between 7 and 42 days after administration of the IGV-001 prior to initiation of standard of care. And that's a really important point there, because we know that chemotherapy and radiation can both be quite immunosuppressive, and so that time period becomes crucial. There's a progressive increase in expression of chemokines, cytokines, macrophage function pathways, TNF and TNF receptor superfamilies at both days 28 and 90 after treatment, a decline in the regulatory T cell signature that happens after treatment, and a correlation between elevated IL-7 levels with absolute lymphocyte counts and a more favorable clinical response. So really, in conclusion, IGV-001 is a personalized autologous whole tumor cell-based immunotherapy. It was found to be safe and mediated potential efficacy in patients with newly diagnosed glioblastoma, particularly in those patients who were receiving the highest dose and exposure, and particularly in those patients who were Stoop eligible. We saw a dramatic benefit, near doubling of overall survival from 16 months to 38 months in that cohort. And these were the findings that informed and allowed for the follow-up phase 2B study. And so this just rolls right off the tongue, but it's a randomized, multi-center, double-blind, placebo-controlled phase 2B study to assess the safety and efficacy of IGV-001, which is an autologous cell immunotherapy with antisense oligonucleotide IMV-001 targeting IGF-1R in newly diagnosed patients with glioblastoma. So this is the process, just kind of diagrammed out here. Tumors excised. The tumor cells in the antisense oligonucleotide are commingled and incubated. They're placed in biodiffusion chambers and they're radiated to prevent cell proliferation. These chambers are implanted into the abdomen below the umbilicus to drain into the inguinal lymph nodes. They stay in for 48 to 52 hours, so 48 plus 4 hours, up to 52. And then the chambers are explanted. What are the advantages relative to some other immunotherapeutic platforms or approaches? So this gives you the full antigenic signature, broad spectrum immune activation with no off-target effects. There's rapid overnight tissue processing, and it can be integrated into the standard of care because it all happens prior to the standard of care during the index admission and operation. So the primary objective here was survival without worsening of disease, the secondary objective being overall survival and safety objectives. So this is building on the groundbreaking phase 1B data. And there's, again, a randomized multi-center double-blind placebo-controlled phase 2B study. And I think that's absolutely critical. And I think, it is an initial shock to some people. So these, whether you are randomized to the control group or the active agent, you are getting the same treatment, you're getting the same implantation, and it's double-blinded. It's comparing efficacy of a one-time treatment with IGV-001 at that maximum dose, 20 chambers for 48 hours plus standard of care, compared to standard of care alone. This just finished up and really had rapid enrollment given the complexities of this trial. It was really impressive. 99 patients were randomized in a 2-to-1 randomization scheme at about 20 sites in the United States. Again, primary efficacy is progression-free survival with secondary endpoints like overall survival. And PFS data expected maybe mid-2025. We're now in just data collection phase and follow-up, and then overall survival data hopefully mid-2026. So study design and the periods. So screening is day -14 to day -3. Discussing with patients whether this trial fits with you. Patients 18 to 70 require an MRI within that time period, and then screening and randomization. So a patient would undergo surgery, the tumor would be removed, they would be randomized once frozen section confirmed a malignant glial tumor. That tissue would be whisked away by courier to one of the facilities to be processed and then returned 2 days later and implanted into the abdomen. Again, this is implanted into the abdomen under the rectus sheath on top of the rectus muscle, so not in the actual abdomen or peritoneum itself. Those would stay in for 2 days, and then they would be removed, and thus would essentially complete the actual interventional portion of the trial. Patients would then be examined as really a standard at 14 and 28 days, and then would initiate standard of care chemotherapy. Okay. Eligibility criteria is slightly different than the phase 1 trial, where there were tighter inclusion exclusion, really based on where we saw the strongest signal in the phase 1 trial. So they've got to be willing to give consent. Karnofsky greater than or equal to 70. They have a diagnosis of malignant glioma, again confirmed on frozen section, confirmed measurable disease, and supratentorial tumor. So this excluded patients who were older than 70, bihemispheric or multicentric disease, recurrent tumors, patients who were immunocompromised. And this also, which has always been a little sticking point in some of these newer trials, is also excluded patients who were going to receive Optune or tumor treating fields. Again, these are listing of some of the sites. Again, all kind of focused largely in the Northeast, Mid-Atlantic. Again, going out to Ohio and Wisconsin. And here's just some information, clinicaltrials.gov, and some information for patient and families. And I'm happy to take any questions.
Oh, thank you for that presentation. That was great.
Yeah.
This is a really exciting therapy.
Yeah.
Um, let's start with, let's see. Um, So for the median progression-free survival for the gross total resection group, you had said they didn't reach that as of that, I guess, that publication date. And I think I also read in one of the abstracts that for the MGMT methylated patients, they had that were stoop eligible, they had a really impressive progression-free survival of somewhere around 3 years, but
Yeah.
overall survival was not reported. And I assume because it wasn't mature yet at that point.
Yeah, that's a great. Yeah, so the median progression-free survival in the Stoop eligible MGMT methylated cohort, of which there were about 10 patients, um, was 38 months. Was the median PFS, and I think you're absolutely right. Overall survival median was not met. Um,
For the gross total resection patients.
yeah, well, for the gross total section, I think it was met here. I'm trying to
Okay.
see kind of yeah what was I think it was in the so this was a subset of the Stoop eligible patients who underwent gross total
Total
resection.
resection.
That,
Yeah. I was just
that
wondering, will there
yeah
be a follow-up publication on
yeah, it's a great
these endpoints that
question.
weren't met?
Yeah, that's a great question. Certainly could bring that back to IMVAX and to Dr. Andrews to see kind of how that data has matured. My sense is this is a relatively small number of patients, um, right? And so there were only 10
Hmm.
patients who were Stoop eligible, and again, a very small fraction of these patients, only 30% of them underwent gross total resection. So I assume that that Venn diagram of gross totally resected Stoop eligible patients is in the single digits somewhere. And so how
Okay.
much to rely on that, I'm not sure. So I don't know if they're going to come out with that data, but I'm sure they have it at hand.
Okay.
But again, I think that was the idea is that's where kind of the biggest bang for their buck I think was seen from this therapy, and so that was the first cohort to use it in. And that came up several times throughout, as the trial was kind of ongoing. I know a lot of investigators, including myself, you'd have a patient who was a little bit outside the age cutoff, but was very robust and a great candidate. And I think they wrestled with that too. But the trial was accruing very quickly, even with these somewhat, I'm not terribly stringent, but somewhat stringent. And a trial that is different. This is very different than taking a new chemotherapy or trying a different radiation technique. These patients are having two additional operations. I mean, they're relatively minor operations. And I think
Hmm.
as the platform matured, I think as each individual center um, did more of these cases, people got more comfortable. I started based on patients and how they're doing. I'd send people home after we did the implant, and then they would just come back as an outpatient 2 days later. We'd take them out and they'd go right home. So I mean, it's certainly not a big deal. People were doing it at the bedside in the ICU. Some people were doing the OR, and they left a lot of flexibility there. I think it's going to be important, as if what we all hope that this is proves to be as valuable as we think it may be, and then as we need to bring it kind of more into the mainstream and make it available for everybody. So.
Okay. And why did you choose the stomach to implant the biodiffusion chambers? Why was that the location?
Yeah, it's a great question. So, again, in full disclosure, right, I am, I have very little to do with IMVAX as a company, and just my site PI and have enrolled a number of patients in the trial. So I probably can't speak specifically to why they've chosen those areas, but the reason is to access a robust immune site. And I think it's probably a combination of scientific reasons, rationale. So certainly below the umbilicus, it drains into the large collection of inguinal lymph nodes. It's a safe area. It's an area that most neurosurgeons are very comfortable with because we do a lot of other procedures like shunts where we have to go in that area or put in batteries and things like that. And so I think it's both a practical, kind of safe, straightforward place to do it, and also a robust site of the lymphatic drainage that is going to provide kind of significant activation. So what went behind that specific decision, I can't comment on, but I'm not, that's my presumption.
Do you think we'll see more of that, trying to generate an immune response outside of the brain that will just
Absolutely, absolutely. I mean, again, I know you this this is their platform is really agnostic to tumor type, um, and so Dr. Andrews is a neurosurgeon, so obviously that's where his initial focus was, and that's why this is the most mature portion of their platform. But the idea is that this may work in a variety of other really challenging solid tissue malignancies, and so I think this strategy makes a lot of sense.
And we're seeing in some of the other vaccine trials, they're using combination strategies where they're adding like an immune modulator or a checkpoint inhibitor. Do you see that in the future for MVAX?
Yeah, I think
IgG001?
yeah, again, I think there's no question that some kind of combinatorial approach um is going to, I think, kind of be the thing to drive the field forward, not any one single thing. Um, and it's the unfortunate reality of kind of where we currently stand with device and drug and development of glioblastoma. I mean, with many cancers, but glioblastoma in particular. I mean, it's hard. It's hard, when you have several unproven therapeutics to, I mean, I think on the one hand, you want to just throw everything at it, but on the other hand, I think we've been fooled before by a variety of things that we thought might make an impact, like single agent immunotherapies, checkpoint inhibitors that have proven really not to be valuable in the broad cohort, where selection criteria, molecular testing, and understanding the depths of each individual tumor becomes so important. So I'm sure that's a future thing, where there may be some combinatorial approach. But I think testing these things individually is going to continue to be important. It's that balance. I think it's really challenging.
Okay. And how does this compare to something like DC Vax that just had their, phase 3 study published last year?
Yeah. Yeah, I think the approach is just somewhat different, and I think this uses the entire the whole tumor, and so I think having that entire antigenic response is, I think, what separates this apart, and really with no off-target effects because it's in the biodiffusion chambers, and kind of setting the immune system like that. So that's my sense. But again, is that something that's going to be complementary in the future? Where the role is and where that's going to um, how that's going to play out, I think just time will tell. Yeah, I'm not really sure yet.
Okay. And speaking of complementary therapies,
Yeah.
Optune wasn't allowed in the phase 2B trial. So what was the rationale for that? And do you think maybe the future phase 3 would allow Optune?
Yeah, it's a great question. I would gather future, like a larger phase 3 trial would probably allow Optune. Um, Optune remains one of these semi-controversial technologies where I think the it depends who you talk to, it depends on the oncologist or the surgeon, where I think that there's compelling phase 3 data, but was not blinded. And I think it's called into question a little bit, but um, and I think it's also a challenge for a lot of people to do. It remains a challenge. I think that's a technical hurdle that will be overcome. But I think it just remains a little muddy for some of these newer novel therapies where they're trying to get as clean a population, and clean a data as possible, um, so that we don't end up in a position where patients have undergone these therapies and we end up 2 years later with no answer. I mean, I think that's the balance between offering everything and saying, look, you could use it at the time of recurrence, and that's obviously an option. And there's you proven benefit there as well. So, yeah, I think those are challenging decisions.
On the patient
And that's something
advocacy side, we always push
yeah,
for the trial design to, we have so few approved, FDA approved therapies
try,
too.
yeah, yeah.
So,
Yeah,
okay.
no, I know that's such a challenge. It's such a challenge. I mean, we tend to kind of, again, at our center, it's something we offer. We tend to offer it in the upfront setting. I think a lot of places have gone towards that, is trying to include it as part of the standard of care, kind of the upfront disease. Yeah, and I'm just curious from the patient perspective, patient advocate perspective, how you see it, because it's definitely not caught on in the way that I think if it were a pill would have caught on, I think, right?
Absolutely. Yeah.
Yeah.
We My husband is a GBM patient and he wears Optune, and we felt very strongly about it. Turned down a phase 3 trial because it didn't allow Optune.
Interesting.
Um,
Yeah.
so, as a NCCN,
Yeah.
first line guideline, and I understand definitely the side of the difficulty to wear and the patient resistance to compliance, but
Yeah.
we definitely like to see it not being
Yeah.
exclusionary for
Excluded. Yeah.
trial.
Yeah. An exclusion criteria. Yeah. No, understood. And again, I don't, the rationale behind that, I'm not quite sure. I think it's probably largely to get kind of cleaner data. Um, uh, but
Okay.
because it would have, I think it's hard when you can't mandate it
Hmm.
and not every patient's going to do it. And so then you're going to have a subset of patients who are
Of
doing
course.
it, and it's going to really, I think, muddy the trial. So you're right. So you end up if 50% of the patients take Optune and the other don't, and then those 50% of the patients do better, what are you left with?
Yeah.
Was it an Optune effect? Was it not? And so I think it's an all or none. And I think it's hard to force people to do Optune. So I think that's what it is. I mean, it's hard to mandate it. It's hard to for people to comply. And like you
Sure.
said, I think the way I see it in my practice is you get two different cohorts of patients. There's some patients who are like, look, I want it. This is easy. It's not going to hurt me. It might help me, and I feel like I'm doing something for myself. And then there are other patients who are like either too old or frail, or just say like, look, I just want to get back to my life, and I don't want to walk around with this thing and be
Hmm.
bothered with it. And it's a reminder, and I don't want to deal with that. And I would say that ends up being the majority of people.
Yeah.
But it's certainly something we offer and certainly encourage.
Okay. I was really interested about, I think one of the abstracts from Snow from the
Yeah.
Society for Neuro-Oncology conference last year. They mentioned the potentially identifying a blood marker that correlated with outcomes, the neutrophil to lymphocyte ratio. Can you
Yeah.
speak a minute to that?
Yeah. So again, I think that was from the phase one,
Okay.
where they saw that signal. And again, I think just speaking to the mechanistic approach. And so again, here's the last bullet point, but this correlation between elevated serum IL-7 levels with a higher absolute lymphocyte count, and that predicted a more favorable clinical response. I mean, the beauty of this trial is um, a big part of it was immune biomarkers. And I think that's something that other like large scale, some of these large scale immunotherapy trials have really fallen short of. You're going to spend lots of money and lots of patient involvement to do these trials, and then not collect the tissue or the blood or the serum that's going to allow us to say, well, maybe it didn't work in everybody, but maybe this subset of patients is going to work in, and how do we know that? And so this trial did just that. And so immune markers were collected at baseline at multiple additional time points. And
Okay.
so I think there will be a lot of additional information that will come from this phase 2B that will inform that, right? And so maybe it will be just a cohort of patients with specific immune markers at baseline. Maybe we'll see a real signal that'll allow us to see early um, whether somebody's going to respond. I know that's kind of one of the holy grails for us is how can you sense impending treatment failure or response before an MRI shows it and maybe change strategies. And so I think there'll be a lot coming out of that. There's definitely going to be a lot on the back end um, looking at that data that I think will be really interesting.
And so the 2B trial has just completed, like last week, completed
Correct. Yep.
enrollment.
Yep.
And I believe, I checked the IMVAX website, and currently they do not offer expanded access. Or per the
Mm.
website, that's what it says. Do you envision or have you heard whether there might be an option for expanded access for
I
patients
have not heard. That's a
within
great
the
question. I have not
next
heard.
2 years? Okay.
Yeah, I have not heard.
Okay. Has there been any talk of timeline for a phase 3?
Um, Not that I'm aware of. I think they're gonna wait for some of this data to mature. Um, at what point, again, it's like at least kind of what I've been told is some early PFS data in mid 2025. Whether they're gonna have enough signal prior to that or do an interim analysis before that, I don't know. Yeah, I
Okay.
know those is so tough, kind of waiting these out.
Okay. Yeah, because we'll have a lot of patients that will watch this and be excited about it and want
Yeah,
access.
these are good questions, and I certainly appreciate them. And I'm going to bring some of these back, the ones that I'm not able to answer, um,
Okay.
to Dr. Andrews and the IMVAX team.
Yeah, and kind of along that line, then, how do you counsel patients that maybe, don't qualify for trials either because they're multicentric or they're infratentorial or,
Yeah,
whatever the case may be, and kind of how does this trial fit into other things you're working on
yeah,
at UPenn?
yeah. No, absolutely. Again, I think you know what many of us who do this for a living, we and as patients and patient advocates and family members, we know that what we have isn't good enough. And so we are just constantly looking for something else. And so I think most kind of centers that do this at a high level, even patients with multicentric disease, even patients with bihemispheric disease, or patients who may not be eligible for a trial, we are always willing to kind of push the envelope, right? And consider alternative treatments in addition to the standard of care. That's doing broad spectrum molecular testing, and looking at mutations that may be exploitable, whether that's doing things like laser ablation for multifocal or deep-seated disease, radiosurgery for multifocal disease, um, brachytherapy, with gamma tile. We're constantly looking to see what else we could do, and then bringing every clinical trial that we could offer to bear and trying to constantly um, push the field, because we rely on patients being willingness to participate, and helping others. Yeah, it makes just such a big difference.
Of course, yeah. And I got sort of a specific question that I'm not sure if this
Yeah.
is a PI question or an MVAX question, but
Yeah.
it's from a parent whose son is in the phase 2 trial, and they're asking if they will ever know if he received the treatment or if he was in the placebo control.
Um, Great question. I would gather at some point, like everybody will be unblinded,
Hmm.
but that will probably, I assume, will be when the results are
After
mature.
results are published.
Yeah, and we'll be blinded until then. I mean, unless there's a compelling reason to unblind either the patient or the provider.
Okay.
Um, and so, but I think in the long term, that will be something people, will be able to find out. Yeah.
Okay. I think that's it for our audience questions. Al, did you have anything before we close?
Yes, just one more question.
Yeah.
Can you just tell us about the other trials that you're offering at Penn?
Yeah. So um, we have several phase 0 trials, which I know are not super appealing in some ways, but looking at a class of drugs called the azoles. These are drugs that are commonly used, like fluconazole, antifungal drugs that one of my colleagues has found some efficacy kind of in in preclinical models. And so we're offering that, and that really has very broad inclusion exclusion criteria. Those patients are basically take one of these classes of drugs leading up to surgery. They have surgery. That tissue is then harvested, and we put a small catheter, what's called a microdiatheter, that's left in place for 24 hours. We're able to sample from the brain tissue right around where there is, and the idea is to see whether the agent gets there, whether this oral agent gets there. Because if it doesn't get there, then there's no point in kind of moving forward. And so that's kind of where that phase 0 trial is. Um, we are have several trials for other tumor types like primary central nervous system lymphoma, rare tumors like craniopharyngioma, meningioma, metastasis. In addition to the glioma trials, we're about to bring on the Sonneberg trial for recurrent glioblastoma. That's an implanted ultrasound for blood-brain barrier breakdown. Um, and have several non-interventional trials looking at CSF and blood diagnostics, for tracking disease using proteasome technology. Um, that's been quite interesting, kind of again to that that topic we touched on briefly about understanding treatment resistance, treatment response, impending treatment failure, and trying to understand that better than what we have now, which is really this kind of very rough looking at an MRI, sitting down together and saying what we think, very kind of unsophisticated, and so trying to look for complementary markers.
Great. Thank you for sharing. And we'll close. Thank you so much for
Thank
sharing
you.
this information, the presentation, and answering all of our questions. We appreciate your time and expertise.
Absolutely.
Thank you for
Take
coming.
care. Thanks, everyone. Have a good night.
Thank you.